Hi everyone, Bryan Lewis here with KidneyCAN. It's my pleasure to welcome you back to another joint edition of the National Kidney Foundation and KidneyCAN's NKF Live series. And today we're going to be discussing the topic of palliative care and kidney cancer treatment. And my guests today include Dr. Koncicki, joining us from Mount Sinai Hospital in New York City. She's a practicing nephrologist or a kidney doctor, and she's also a practicing palliative care physician. Welcome, Dr. Koncicki.
Thanks for having me.
Thank you for being here. She's got a strong clinical and educational focus and is considered an expert in the intersection of kidney disease and palliative care. And also with us today is Glenn Sykes. Glenn's been here before. He's a person living with kidney cancer. Glenn's a retired University of Chicago Booth School of Business Dean of Students, and he's graciously agreed to share his experience with us. Thank you, Glenn, for being here today. So I'm going to get started off right away. A lot of people misconstrue palliative care with hospice. Doctor, tell us some of the things to keep separate here.
Yes, that's a really common misconception. Palliative care is really an approach to care that is focusing on improving the quality of life of patients and their family members who are facing a serious or chronic illness. Palliative care can be delivered at any age and at any stage of illness, including alongside disease-specific care or even curative care. It's really a big umbrella term. Hospice is a very small, subspecialized piece of care that is within palliative care, but is focused more at the end of life.
Got it. Okay. So can you walk us through a sort of a typical appointment, and then Glenn will find out what you did.
Sure. So how do we focus on quality of life? So we focus on a lot of different parameters. So symptom management is really one of the big key factors that we try to focus on. So sometimes patients that might be receiving oncologic or cancer care, or even patients living with other chronic disease can have symptoms related to either their disease or the medications. So we try to evaluate what's interfering with quality of life and their activity and what we can do to help with that. In addition, we focus on really assessing the patient's understanding of their illness, of their treatment options, and try to learn a lot about who the patient is, what's important to them, and how living with this illness is affecting their day-to-day life. And we also want to explore what worries them about their illness, about their treatments, and about the future. And together we just try to make sure there's really clear communication about what to expect and that they're getting the information that they want from all their doctors.
So it sounds like it's a lot of softer science here rather than data, and it's getting into what's going on with the patient themselves. So is that correct, I guess? I hope so. Glenn, let's hear your story on your introduction to palliative care.
Sure. Thanks, Bryan. I think with Dr. Koncicki, I agree with everything that she said in terms of reflecting my own experience. I was living with cancer at 13 years before I introduced palliative care into my treatment plan. It was through speaking to my oncologist that I expressed an interest in palliative care. And it's interesting, in my case, I wasn't dealing with any side effects or adverse side effects, but what Dr. Koncicki said about affecting my day-to-day life, the quality of my life, there are things at work. And so that was driving my need to see a palliative care doctor. And I really am glad that I did. And we touch on a lot of these things: quality of life, my emotions about cancer, my relationship with my oncologist, relationship with family, really broad reaching topics. And it's a really valuable appointment, I think, to have in the overall scheme of my care plan.
Quick footnote here. We learned that the term, for those linguists out there, that palliative is Latin derivative for the phrase to cloak, which means to cloak or cover over suffering or from illness. So I'm just curious, sounds like you get some time to spend with the patients to talk to them about things that you might not otherwise get to talk about. Are you limited in your amounts of time, or do you set appointments for a certain amount of time with patients?
So I think that every provider will have different appointment lengths, and not everything is going to be covered in one visit. So it's really about establishing a relationship with the patient, and you might touch on some topics at one appointment, and then at the next appointment you might explore that further, and then learn some more about the patient and how they're feeling. So there's no really checklist that we are trying to hit certain topics during that visit. It's really letting the patient guide the appointment and, extending that care into the future appointments.
So it sounds like, is Glenn's situation typical where he approaches the healthcare professional, or is it usually you all that suggest to the patient?
It can be variable. So I think it's so amazing that, Glenn had the insight to say that I think that this could be helpful to me because, some people might not, have that, may not feel empowered to do that. But a lot of times it could come from their doctor or their provider saying, you should see a palliative care specialist. We worked as a team. We work together. But it can come from a whole, varying referrals.
So speaking on my own behalf, I didn't know what the word palliative care meant when I was first diagnosed. Did you come to learn about palliative care as you were going through this?
Well, it's a good question, and I maybe simplified my path to palliative care. And I certainly remember in the early days of my disease when the term palliative care came up, it was generally with a really serious look and sort of the assumption that this was the last thing for someone to do. And so I went with trepidation to talk to my oncologist about palliative care because I always associate it sort of with the end stages of disease. I've learned more about palliative care by participating in my palliative care appointments. And in terms of a cadence, I see my palliative care doctor about once a quarter. And through that, I've learned that it is exactly what Dr. Koncicki said. It deals with everything about quality of life. And when you're a cancer patient, there's a lot of things that affect your quality of life. Whether you have side effects or don't have side effects, I think obviously it's important. But I don't think there are other things that do affect your quality of life. Just managing your disease, and in my case, managing disease for now going on 14 years.
Got it. So are there other members of the care team in addition to you that are involved in this? Can you comment on that?
Yeah, so the palliative care team usually incorporates a doctor. It can have a nurse or a nurse practitioner, physician's assistant. There's a social worker also usually involved. Some larger centers might have chaplains or child life therapists as part of their team as well. But really the doctor, nurse, social worker are really at the core.
At the core of what's going on. Okay. And it looks like getting to know the palliative care specialist earlier is a better thing.
Yeah, absolutely. I mean, they have done studies looking at patients that have metastatic lung cancer, for example, was a really big study that came out. And they had patients who were diagnosed and received standard cancer care, and then another group of patients that received standard cancer care, but also palliative care early on in their treatment course. And the patients that received palliative care not only had a better quality of life scores, but they actually lived longer. So the thought now, and it's supported by a lot of the national oncology associations, is that palliative care should be incorporated early on in cancer treatment.
And can you talk to us a little bit about the training or the expertise that you have compared to, say, some others?
Sure. So my expertise is a little bit different. So I'm trained in nephrology, and I also did separate training in palliative care. So I'm certified in both. It's actually very exciting because in medical schools and residency and fellowship training programs, they are now incorporating palliative care education so that every doctor that's coming into independent practice will have a primary set of palliative care skills that they are able to use with their patients. Some doctors might choose to do this additional training because they want to either get extra training or practice, palliative care specifically. So that's another option.
And so there are actual specialists out there that this is all they do,
Yes.
100%.
Yeah.
Neat. I'm going to ask you, Glenn, on the finance front, is palliative care covered in your insurance policy, or?
Has been so far, so hopefully that'll stay. Yes, it is covered. It's a question that I also had myself, so before I embarked on the path, I wanted to understand that a little bit more, and the answer so far has been positive.
Is that the case for?
Yeah, palliative care is usually covered by most insurance plans, but if there's any questions, always, check with your insurance plan.
Right.
Sure, absolutely. So you mentioned that there's a social worker and nurse usually, and sometimes a spiritual component. What do you do if you don't have that at your hospital? Do you have alternatives?
I mean, I think that there are probably other community resources that you would be able to refer to if we didn't have that as part of our
You have a
group.
social worker that probably is plugged into a lot of other resources as well. Okay, and hopefully we'll have some resources that we can share with folks. Is telemedicine an option?
Yeah.
Have you done some?
I've done both in-person and telemedicine. In the beginning, it was face-to-face. I thought it was important to have a face-to-face relationship, but we have had a few telemedicine appointments. It's an appointment that lends itself a little bit nicely to telemedicine than sometimes the appointment with the medical oncologist.
Got it. Is there any concern that if you ask for palliative care that it could impact the therapies you're on or any of the treatments that you're receiving?
It shouldn't. Palliative care will not change the therapies that are being offered. It's really given alongside the treatments that you're already receiving. So it's just an added layer of support.
Yeah.
Okay, and so you'll have a separate appointment for just dedicated to palliative care conversations. Let's say you're going in for an infusion on one day, you'd have a palliative care appointment on a separate day?
So you can. So how palliative care is delivered is really variable. It depends on the resources that are at the institution that you're getting your treatment at. So some cancer doctors have this palliative care training. It might incorporate it into their appointments. They might have conversations exploring the emotional aspect of care with their patients during their normal, cancer appointments. But others might have a separate, go see a separate doctor on a separate day and really just have that appointment strictly focused on all of these aspects of care that we discussed earlier. And that's helpful because, you're not trying to put too much into one appointment, that you can really kind of explore more and have the patient really lead that conversation.
And so, Glenn, did you ever consider bringing anybody into a meeting with you, or was it always just you by yourself?
Right now, it's been by myself, but in some of the conversation that we had before today's session with Dr. Koncicki, she asked me that question if I thought about or I had been bringing someone. I haven't, but I clearly can see there might be a good reason to do that, and hopefully I'll have the opportunity to do that in the future.
Do you see that in your practice? I'm just curious, sometimes my wife wanted to know everything and other times she didn't want to know anything, and I'm just curious, in your practice, do you see a lot of trends, or everybody's a little bit different?
I mean, everyone's a little bit different. Like you said, some family members want to know as much as possible, and some, don't. But I think that it's really important to have, your core support system come to at least some appointments, so that just to make sure that everyone is on the same page as to what the understanding is of the, where they are in their illness or where they are in terms of their treatment, and also hearing what worried Glenn. It could be helpful for someone else to know that, and knowing what's important to the patient. It's really important for family members to also be involved in that, because a lot of times they can also be caregivers.
Right.
And when they've looked at what drives decisions that patients make, the stress on their caregivers do play a role. So having caregivers involved in these appointments, can be really helpful.
Yeah, and so I'm curious, there are a lot of topics, I imagine, in these appointments that are, almost psychological issues or, anxiety, fear, emotions. Do you all bring in other experts on those areas, or do you all handle those yourselves, or how does that work?
So, I think that, there's definitely some, mood, mood can play a factor, anxiety, depression are symptoms that can commonly happen. And I think many palliative care doctors will feel comfortable trying to manage those symptoms. But I think that there is a low threshold to, bring somebody else in or have a patient, see somebody else if, the therapies that we start are not necessarily helpful.
Right. And Glenn, you had mentioned earlier about side effects and that impact on palliative care. You didn't have any side effects when you first went?
Right, it wasn't side effects that was driving my decision to see palliative care, but it was at 13 years at the time I came. What does my future look like with cancer? I continue to have metastatic cancer. So I was thinking about those kinds of questions. And one of the things that I think that my palliative care doctor said, which I think is important, that many people that you see in a healthcare practice provide palliative care. They are not monopolists on dealing with side effects. Your oncologist can deal with side effects. But I do feel like my appointments with my palliative care doctor have just a really different tone than I have with my medical oncologist, which tend to be focused on, the treatment I'm receiving. Is it doing its job? Is it not doing its job? If it's not doing its job, what else could be in the works? And with my palliative care doctor, we talk about a whole wide range of topics that, for whatever reason, I'm not talking about at my oncologist appointment.
Got it. So let's take some time to look at some of the questions that folks that are watching have been asking. And I'll remind you all that if you have any questions on this subject, please post them in the comments section and we'll do our best to answer as many as we can. And if we do run out of time, please know that all your questions will be addressed on the NKF and the KidneyCAN's Facebook pages after this program. So here's a question asking about resources that are out there for the public. Dr. Koncicki, can you give some insights on where folks might be able to go to get additional information?
Sure. So there's a website, getpalliativecare.org. It's sponsored by the Center to Advance Palliative Medicine, and it is a wonderful resources for patients and families. So on there you can learn about what palliative care is, what to expect at your appointments. They even have a questionnaire that says, is palliative care something that I should look into? And you can click through and it'll tell you, if you could benefit from it. The other really great part of that website is that you can put in your zip code and it will give you options for palliative care in the hospital, in an office, or at home. Okay. So if you don't know if you have palliative care near you, that's a great way to look.
Could you say that website one more time?
It's getpalliativecare.org.
Getpalliativecare.org. Great. And so just trying to dive in a little bit more on the caregiver front here. So you see some patients with their families and their caregivers all together, and again, you said earlier that you let sort of the patient lead. Is that the way you run that, or do you sort of try to draw out questions from or comments from the family members that are there, or how does that work?
I mean, usually when a family member is there, it's like a team effort. So, we always make sure, the patient's welcome to bring someone. So if they're bringing someone in, we always make sure that they are comfortable with the family member being there and being involved. So we will let the patient ask questions, we will let the family member ask questions, and we try to just help with the understanding through both of them.
Do you ever get stubborn patients that you need to bring the family members in to try to get them to come along, or is that not a problem?
I don't know if I would say stubborn patients, but I think having the support there, can be really helpful. And I think that if I'm, maybe worried that the understanding is not there, the communication with the other doctors is, not really being clear, I really do encourage that other family members come in just so that everyone can be on that page.
Well, and I would imagine sometimes you could almost argue that the caregivers need some palliative care at times. Is that fair?
Yeah, absolutely. I think that, caregivers are so important in, the care of patients and their family members or their friends or, whatever the relationship is. So really, supporting them and, it's also affecting their quality of, or their, day-to-day life as well. So really just, helping support them.
So help me understand, when there's medical records for everything, it seems like, and when you go in for blood, you get all your ranges and everything printed out. With palliative care, do you get a report of what you talked about, or how do you keep track of, so the next time you come back, you can maybe move a little further downfield?
That's a really great question. We would document in our notes, what was discussed. I know that at least at our hospital where I work, we do have documentation when we have a meeting and we discuss, more big picture goals. We will provide like patients and family members with kind of like a little synopsis of that. But it's not like you would get a lab printout like you would at a kidney doctor's office.
Right.
Have you gotten anything?
Yeah, I was going to say one thing you touched on, which we have covered, but maybe it's worth saying, amplifying, is that your medical oncologist appointment is very driven by labs, scans, treatment options, and that drives, I think, many of the bulk of that time at that appointment. With a palliative care doctor, I feel like it's very patient-driven, which means it can touch on many different things. It's not restricted to talking about labs or scans, although those things may affect things you talk about. And so I think that is a good mindset to take into it. And it takes a little while. It's been a year, a little over a year now. And it's still, I think, taking some warm-up time to figure out how do these appointments work, what do we talk about, but the fact that it's patient-driven is a good mindset to go into those appointments with.
Right.
And so, and I'm trying to understand, do you ever pass off patients to it? I don't mean pass them off, but do you, if you have to, your schedule's full, does someone else step in to be able to follow the conversation over months at a time, or how does that work?
I mean, I usually try to keep continuity with patients. So if I'm seeing someone, I will want to continue to see them, unless, of course, I'm out on a leave for some reason, and then I would, have somebody else establish a relationship with them during that time. But, I try to keep that continuity.
And do you have any certain goals in your first or second or third meetings that you need to get to understand how to move forward or help the patient move forward?
It's really patient driven. I mean, usually I want to hear, I would be like, Glenn, like, tell me what have your doctors been telling you? What do you understand? What's confusing to you? So that's really my goal, is to just get a sense of where, he would be at in terms of his understanding and, what's worrying him and what's on his mind.
Yeah, I'm curious because I refer to that early diagnosis stage as the white noise stage, where everybody's speaking to you and it just sort of flies through. So do you ever find that you're talking to a patient and they have an entirely different understanding of what has taken place?
Sure. Yeah, absolutely. I mean, and that's why it's so important to say, like, what are you hearing? What are they telling you? And that's why it's also important for family members to come, because if, a patient hears 5% of what the doctor's saying and the family member hears 20%, well, at least then that's 25%, because it's a lot of information that you're getting at a really vulnerable time in your life. So it's really just so important to make sure that is clear communications happening.
And then do you send, or I shouldn't say it that way, do you give any homework to the patients when they've been to a meeting with you or an appointment with you?
I don't know that I give homework. Do you?
I received homework,
Yeah?
not my first appointment, but I think it was the second appointment that I received a little homework. My fundamental issue is now 14 years in, I'm not getting cured. What does that mean? And I continue to have treatment. So that was sort of, I think, the fundamental issue that drove me to the palliative care doctor. And I think she had me, pen and paper, write out what kind of emotions that brings to me. Fear, relationship with caregivers, and that was I think that was an important exercise, because no one's really asking me that, and it was helpful to ask that, because I think it has set the stage for the other discussions that we've had.
And have you found has it gotten easier over time after you were doing that homework and asking those tough questions, or being asked?
Easier in my palliative care appointments?
Yeah.
Oh, absolutely, because you sort of go through, when you're managing disease, just managing the disease and trying to get rid of it. And what if you're not getting rid of it, it's still there. What does that mean in terms of your future? So I think thinking about that, so you don't spend a lot of time thinking about it, but at some point in time I felt like this is something I need to think about, because maybe it's going to be part of my life forever.
Right.
And so I think that was a really worthwhile. And from that, we've kind of branched off to different topics, I think, and that's been helpful.
And you said you've been doing this for a little over a year.
Yes.
How frequent have you been going by?
Right, my cadence is about every 3 months, and whether that's the right cadence or not, I don't think we're completely sure. I think Dr. Kumar has left it to me to decide if that feels like the right one. So far, it has felt right because we do have things to talk about. At some point in time, it occurred to me that we might want to meet more frequently if more things are to talk about, or less frequently if I feel like there's less things to talk about. And again, these appointments are very patient-driven, so I think largely it's left up to me.
All right, here's another question was thrown in here. Will my palliative care doctor have a deep knowledge about my cancer? And that's probably a maybe.
Yeah, I mean, I think the oncologists are the experts, right? They know everything about cancer and treatments. We know a lot, and we will confer with the oncologist to understand from their perspective, what's going on and where someone is at. So we do have an understanding, but we are not oncologists. They are the experts.
So we talked about emotions and feelings. What do you do if a patient comes to you with financial challenges?
Yeah, that's definitely a worry that I think a lot of patients and families have. I would try to get the social worker involved to see if there's any resources that they can suggest to help.
And one of the things the patient community talks about a lot is wishing that more institutions were able to subsidize things like parking and travel to a hospital, or if you're participating in a clinical trial, being there. Is that something that you all encounter in the palliative care space, that people would like it to be less friction in order to get there?
Yeah, I mean, I think that making it as easy as possible to come to these appointments would be the most helpful, because it is a barrier to some people that might not be able to afford to pay for the parking, to pay for the transit in, or they might just not feel like they have the energy, or they don't feel up to it. They're coming to see so many other doctors, coming in for treatments, and to come in for another appointment. And that's why I think telehealth has been such a asset to medical care, because that could be a really important avenue for people to explore, and an easy way to access palliative care.
So I'm going to throw a little bit of a curveball here, but hopefully not too wide of an arc. Palliative care, a brand new term for me when I was diagnosed. Took me a while, still learning about it. What about people who are not, say, from here, native English speakers? You have to describe palliative care to them. Do you have an easy way of sort of defining that for them?
I think I would really describe it as just an added layer of support to the care that they're already receiving. We're just an extra team that will help care for them along with their other doctors, to help with their quality of life. So help making sure that their day-to-day remains consistent with what they value and what they enjoy.
Right. And do you all provide any kind of services outside of office hours? Or is that,
For example,
I don't know, if someone like at midnight feels emotionally upset and they needed to speak to someone about what's going on, is that something that falls within?
I mean, I think we have like a call center, so you could call and somebody would get back to you. But I don't know. Do you have any?
A palliative care emergency?
Yeah.
I haven't had any personal experience with that. I can imagine the topics that we talk about may take on a sense of urgency.
Yeah.
Whether it has to be dealt with at that moment or dealt with at the next possible moment,
Right.
I think is where I would see it. In which case, I think my palliative care practitioner would be open to saying, we don't have an appointment for 2 months, but something's come up. I want to see you sooner. And I think I would think of it that way, like moving up an appointment rather than having to run to an emergency room or something like that.
So I would say if someone is if we're managing symptoms and
Yeah,
there's really
true.
severe breakthrough symptoms, that's a time to call. Somebody is going to, call back and make a recommendation about changing the medications or whatever it may be. So in that situation,
Right.
yeah.
So just sort of back to this idea of, needing to speak to someone or have someone to contact with. Do you ever see that people are concerned they're going to lose their existing doctors if they move on or have conversations with palliative care?
I mean, that's a really common misconception is that, and it's incorrect, that you would have to give up your relationship with the doctor that you already have. We are not taking anyone away from their doctors. We are working with their doctors. So you would continue seeing the doctors that you're seeing, and we are just added to your treatment team.
Great. The added layer of support.
The added layer of support.
Got it. So we're starting to run out of time here, but I want to see if for folks back home, any nuggets, any sort of takeaways, Glenn, that you can give to folks that are out there that have maybe been hesitant or didn't know about palliative care now?
Sure. I think, as we talked about in the beginning, I hope this program has eliminated your misconceptions about palliative care. I cannot help but think that what we talked about, how the disease is affecting your quality of life, day-to-day things that come up in your life, can apply to everyone. So, take the time to understand what palliative care, use the resources that have been mentioned to find out a little bit more. In my case, I feel like it's enhanced my cancer care in a way that I didn't expect, and I would urge you, if it sounds from what we talked about, this could apply to you, and I can't see where it can't apply to almost anyone who's managing a chronic disease. Take the next step and find out a little bit more about it.
Dr. Koncicki?
Yeah, and I would just, agree. I would encourage, if you think this could be helpful to you, check out that website, see if you, think it could be helpful. Talk to your doctors about, potentially being referred or refer yourself to see a palliative care doctor and give it a try. And if it's helpful to you, wonderful, continue it. And if you don't think it's helpful for you right now, there's no obligation. Like, you don't have to continue that care. But if you think it could be helpful to you, I would really recommend trying.
Great. Well, thank you both. I think this has been really helpful at least for me, I hope for you, to understand a little bit more about this whole added layer of support out there. We've got to get over these misconceptions about its correlation with hospice. It's an entirely different matter. So unfortunately, we have run out of time, but in case we didn't get around to answering your question today, please, again, check back on our Facebook pages, and we'll be posting answers throughout the coming days. I'd like to especially thank our sponsors for their generous support in making this program possible. And especially I'd like to thank Glenn and Dr. Koncicki for helping us out and joining us today, making sense of what is a misconstrued, common misconstrued issue. So thank you very much for sharing today. Appreciate your time.
Thank you, Bryan.
Thank you.
And on behalf of the National Kidney Foundation and KidneyCAN, I'd like to wish you all good health. Thank you.